Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time to join me. As always, guys, so grateful for all the support. Really appreciate all the comments, the likes, the sharing, what else do people do? Subscribing. All of that is really amazing. So thank you for helping the podcast grow. The goal of the podcast is to help our community, help our profession to be better, to grow. And I love to bring on guests who can help us think a little bit differently and help us practice a little bit differently. And my absolute wonderful guest, Dr. Amrit Bilkhu, is definitely one of those people who I've been wanting to have on the podcast for a long time. I'm kind of glad I waited a little while because really, your repertoire has really rounded out in the last couple of years. Let me give you a really quick synopsis of Amrit's resume, and then we're going to dive in and she'll tell us a bit more about herself. She is an ICO grad. She has a residency in VT. She has multiple fellowships, FAAO, COVD, and on the wait list or waiting for the third one to come through soon. She is also co-owner of a practice in the Toronto area called Northern Sight Optometry, which is a new practice, just opened in 2023, 2 years old. She mostly practices pediatric care and binocular vision. And she is also the host of multiple podcasts. Look, I know how much time it takes to do one podcast. You have two. So we'll talk about that. That's awesome. Amrit, thank you so much for coming on.
Oh, I'm so sorry.
No, cutting me off already. Classic podcast host behavior. It's all good. Good.
I was like, it's kind of like when people have like their second kid, they go like, I don't know where the second one came from. It just showed up. And the second podcast just like popped into my life.
Right. Well, what I could tell you is having 3 kids, that when you have the third one, it's not as hard as going from 1 to 2. So you might as well start a third podcast sometime.
No, I don't have time for that much, but thank you so much for that introduction. No, I agree with you. I'm really excited to be on the podcast. We've been talking about it behind the scenes for potentially having me on the podcast, for the last like 2-3 years. But no, I agree. I'm definitely in a different place in my career. And I have a different perspective of optometry now compared to 2-3 years ago. And so I find like this is the perfect time to come on and, share my experience in peds and scream at everybody to pay attention to the BD,
There'll be
functions.
some screaming. There will be.
A little bit of screaming, just a little bit.
We probably, we were talking offline just before we started recording. We probably won't have enough time to go through everything like in depth the way I would love to do it. Mm-hmm. I know with you, we could go on so many different tangents and have a really, really fulsome conversation. And we will anyway, but we may have to come back and revisit some of these topics because we may only scratch the surface. But why don't you start with telling us a little bit about yourself? What I really want to start with, if you don't mind, because we're going to work through your career as we go through the questions, but start with when you graduated and what were the first few years of your career like? What were kind of some of the struggles and how did you overcome those?
When I graduated, so, I'm from the Toronto area. And so I went to school in Chicago, residency was in California. So very different patient populations, different cultures, exposures. Coming back to Ontario was a huge shift for me, just also because of like universal healthcare system, like, learning all those things. And I didn't have any OD friends moving back home, right? So I did feel not super isolated, but a lot of the people that I practiced around were Waterloo grads. So, that's kind of a tight-knit community. They all know each other and they all practice, in whatever way that they were taught in Waterloo. And so my new grad journey was very similar to a lot of new grads. And for students listening, it's going to be your journey too, guaranteed. It was very corporate and very scattered, right? It was like 2 to 3, I think for 1 year, even 4 different practices that I worked at per week. Yeah. And I was working 7 days a week because they were all sporadic hours. And every single one of those locations, except for one, were more retail optical corporate settings. One was a private practice that offered vision therapy. So I was part-time at that one. I'm still there now, part-time, 4 years later. That journey was tough. And I don't think I need to go into detail because I think no matter what podcast outlet you listen to as an optometry student or a new grad, you've heard the new grad struggles. I went through the same ones. And I found that in a more retail-based or corporate setting, First of all, I was lucky enough in the private practice setting that I could work with another doctor on the same shift. So I got some of that mentorship. Some of those anxieties went away because then I could, counsel, about a patient case with the doctors that I worked with, versus in the corporate settings, I was always there by myself. And so there were a lot of just anxieties of, am I handling this ocular disease situation right? Is this the right follow-up? And so, there were those anxieties. What really led me to leave the corporate world, just 2 years out of, graduating, was a lot of things, but mainly I felt that I didn't have enough time to connect with my patients. My exams were a lot shorter. The workload was a lot heavier. Everything was really emphasized on just prescribing glasses. And I realized patients weren't following up, patients weren't coming back. And every day it was a new patient. I never really had those, patients coming back to build a better relationship with them. And the last thing that I started noticing that just helped me to transition from traditional optometry into this more behavioral, functional world of optometry was that I did every single thing by the book that I was taught to do in school in terms of prescribing lenses. And I prescribed glasses, the way that I was taught in optometry school. If somebody's vision was slightly blurry, I sharpened it up. Every one of my patients tried to leave the chair with 20/20 vision in both eyes, with whatever prescription I could slightly increase to get them there. And the amount of rechecks that would come back, like the amount of patients that said, they're getting headaches, they're a little uncomfortable in the glasses, or my vision's blurry again, 6 months later, I need another increase. And I really wasn't I'm doing everything I was taught. Like, why are these people coming back? And it really hit me when certain cases were coming back that when I decreased their prescription and they went down to 20/30 vision, they felt more comfortable and they loved it. And I couldn't process that because we are taught as optometrists that you will feel so much better if your vision is the sharpest possible. And so, and I know everyone listening has those experiences, in their chair where patients are comfortable with vision that is not 20/20.
Right.
So, that was basically my question that led me to this journey of why is that? Because that's not what I was taught.
Yeah. So let me jump in for a second there, because there's a couple things we're going to keep going down that journey, because I think this is a couple things I want to touch on what you just said. I'll go in reverse order. First of all, that I used to have almost arguments with my patients, like, what do you mean you want more blurry vision? What do you? That's not how you live your life. Like, and also the problem was, this is coming from an emmetrope who's never worn glasses before. So like, really, I'm not in the right position to judge a person who tells me they're okay with 20/25 or 20/30. But again, because I'm going by the textbook, and I was like, no, this is the prescription you're supposed to have. This is the ad you're supposed to have in your progressives, or your reading glasses are supposed to be this strong. What do you mean you're okay with having like a whole diopter less on your reading glasses because you can see what you need? That's not how it works, But that, you're right, it was like beaten into us. You have to prescribe by the book exactly how people, how we've been taught. But finally, I kind of got over my own ego there a little bit and started to say, okay, you know what? You're happy with that? Cool. And now, we have fourth year students in our clinic, right? We have NECO students coming in for fourth year rotations. And that's one of the first things I tell them. I'm like, look, you want to make sure your refraction is really good. It's key. It's the number one, core thing that we're doing as optometrists a lot of the time. But don't overdo it. Let's trial frame as much as we can, and don't worry if you have to cut it down a little bit. Like, just patient. 20 happy is what we're going for.
Exactly.
And for some people, 20 happy is 20/15, and for some people, 20 happy is 20/30. We have to be flexible. And I'm like, look, you passed boards already. Don't worry about what the textbook says anymore. Let's practice real life optometry now. And that's a big part of it. Is like, and it's weird, and even now, still this many years later, I still get caught up in that cycle of like, no, it should be sharper. But I feel more confident, obviously, prescribing differently. I want to go back to one other thing, because being a clinic owner and having a private practice, and a sublease or LensCrafters corporate practice, I do want to make sure I chime in on that a little bit. I know that your experience is one that many people have had in the corporate setting. And the other thing is that, because I just did this conversation with Ryan Court quite recently, about corporate versus private. And if you haven't seen that, unfortunately, I wasn't able to download it and put it as a podcast, which is too bad because it was a really good combo. But it's on my Instagram if you got time to kind of scan through it and listen to it. But first thing I want to just kind of clarify is, like, sometimes we use a very broad brush when we say corporate, right? We paint all of them with this very, very broad brush. And I can tell you myself from my personal experience, having worked in a lot of these different settings, and now as a sublease practice owner over 10 years, that there are quite a lot of, not just like nuances, there's very significant differences between different corporate settings.
Yep.
So I would want to just encourage whoever's looking at opportunities to work in these settings, don't paint every practice with the same brush. And I can tell you, like, some of the things that you were concerned about in the corporate setting that you worked at are things that we work very hard to make sure we don't do in our sublease practice, right? So fortunately, we're busy enough. We have 2 doctors on every day. So if a new doctor was to come and work, they would always be working alongside somebody else. We try to make sure we're bringing in all the better technology. We do Optomap, OCT, axial length, visual field, all that stuff, mammography in our sublease setting, not just our private practice. And we bill accordingly, right? We do glaucoma workups, we do myopia management workups, we do scleral lens, we do ortho-K in our sublease practice. So there are opportunities to work in corporate settings where you can practice full scope, or like quite full anyways. Maybe we don't do VT, for example. We don't have space for that. But I just want to, I'm not
no, I agree with you. I agree with you.
I just want to make sure we don't paint everything with the same brush, because, fourth year students who are coming and working in our practice are kind of like, oh, I was just expecting to spin the dials and give out prescriptions. This is a lot more than what I was expecting to do here. And so what makes me happy to hear that coming from a fourth year who's in school, who's been taught corporate is, corporate is evil, or it's whatever it is, but they come and work in our practice and they actually feel like they're learning a lot and practicing fuller scope than they expected. So I
should add to what you're saying. So, and I've spoken about this on my own podcast as well. No, 100%. There's always there's in any sub area of like how to practice optometry. I think deep down, the core root of any, negative experience of where you're working is usually based on like how the owner is handling their office space, right? So how the staff management is, all of those things put together. And my corporate experiences or retail optical experiences were mainly, I'd say, like a big one was management. Like that, it wasn't really the fact that it was like it was a busy practice. There were always patients coming in. The staff members were really nice, but I just found that my own support of what I needed wasn't there. And that is only for those specific places that I worked at.
And I've worked at places like that too. So I also don't want to paint with my own brush everybody the same way as well. Like there certainly have been retail settings, corporate practices, just like you explained, 5 days a week, 6 days a week, the coming out of school,
same with private practice.
4 different places. Yeah. And not all of them were amazing. Some of them you do just to pay the bills and then hopefully move on. Right. But I certainly have had my own share of negative experiences, and a lot of it, you're right, comes down to leadership, ownership.
Comes down to leadership.
Totally does. Absolutely. If you can find a place, this is you're still a new grad, right? I don't know how you classify it.
God, people are telling me I'm not.
I know, but I would say 5 years, up to 5 years. Now you're saying you're about 4 or 5 year mark, right? So you're like a recent grad. Maybe we'll transition over. But so you'll be able to speak to this, better than I can. But what we're trying to develop in our clinic, and what I think a new grad might want to look for when they're starting to find out where they want to work. And Alexa, of course, Alexa very well. She's your co-host, but she was on the podcast recently. She shared some of these thoughts herself. But it's a weird intangible. How do you feel when you're there? Right?
Yes.
That's so much of it. Like, how do you feel at work? Like, we're all optometrists. Our job is, I personally think optometry is a really great profession because look at us. We're both optometrists, but we practice in such completely different ways. Right? And both find our careers fulfilling for totally different reasons. We were very fortunate to have that. But so find a practice where you go in and you feel good. You feel just like comfortable. Like I look around, I'm not stressed, I'm not anxious, I'm not nervous, I'm excited to talk to the person, the
Mhm.
staff, the other doctor, the patients. I certainly have worked in places where I did not feel that way. I was like,
Yeah.
you know, I got to go there again. But I try to, in our practice, we're trying to create that culture, I guess you can call it, where people just feel comfortable being there. And if you find that, you know, look at that, understand why do you feel that way in that practice, and
Mhm.
try to find more of that when you're working throughout your career.
Yep.
So let's talk about private practice. You're a practice
Yeah.
owner as of a few years
Yeah.
ago. You know, you opened the clinic 2 years ago, but the journey started obviously well before that,
Oh, yeah.
scoping out your location and designing the
Mhm.
practice and all of this kind of stuff. Tell us about how that was, and you know, some of the ups and downs.
Yeah, I eventually, when I wasn't happy with the places where I was working, I found that I liked the private practice I was at because it offered a vision therapy specialty. You know, I figured that adding to what you mentioned before, I think one really important factor for new grads to decide on, you know, where to practice is that autonomy.
Hmm.
So being able to obviously not say, you know, I want to work on only XYZ days and, you know, forget your weekends. I don't want to work. That's obviously there's a compromise
Speaking
there,
like a practice owner now, I'm right now.
right?
Now you understand.
Right. But it's more of the autonomy of if there's a process, you know, that, you know, I want staff members to maybe do for my patients, or there's a way that I like to practice VT that's not in the way that that private practice does it. And I don't have a huge say or sway in how they're going to change things, because at the end of the day, it's not my practice. I'm not making the decisions for what revenue is coming in. And also those that practice has been around for decades. You know, how am I going to really convince some practice that's working well to change just for me? I also find, like, then I think, well, that's kind of selfish of me to even ask sometimes, you know. Um, so, and I love being in. Oh yeah.
I appreciate that, again, as a practice owner, but at the same time, you know, it's not, it doesn't hurt to talk to the owner and make some
No, of
suggestions,
course.
some
I
questions.
mean, you know, suggestions can be brought up, but I also just I like full autonomy. That's the myope of that. That's the myope in me. I'm -7. I want full control. I want to be the best of the best. I want to achieve everything. And so I knew that I wanted autonomy, full autonomy over how I do pediatrics, how I do vision therapy. Um, and I couldn't afford it on my own. And I didn't want to do it alone because I want that mentorship. I want partnership with somebody. And so I was very fortunate enough to find an optometrist who is like-minded and who I get along with very well. Dr. Manraj Farvaha is someone that I've known from ICO for a long time. We, you know, practiced together a little bit at one of his locations, and I knew that his mindset was very similar to mine. So I threw out the idea of opening together, and that took many months, many conversations, activities and exercises to practice, like if we do have the same mindset. And eventually I convinced him and dragged him along with me and said, we are opening this together.
Funny.
And he's not a myope, so he's definitely the nicer, less controlling one out of the two of us.
So
And
that's so
so,
funny that you have, because obviously I have a business partner as well, Harleen, Dr. Harleen Tekar, and
yes.
uh, she's myopic in one eye, so she's the myope in the partnership as well.
Yeah.
But we talked about that before. You know, it's funny, and I think you need that little yin and yang, right? You need the
Hmm.
person who's a little bit more driven in one way, the other person may be driven in a different way,
Yeah.
have a different mindset. So that's
Yeah.
cool that you guys
And
managed to put that
and
together.
that's what I encourage, like, honestly, as a student. I mean, private practice was not in my mind. You know, all you think about is your debt. How am I going to pay off my debt? How many jobs can I get? How many hours can I work? And I want to pay off my student debt. There's no way I'm going to afford a clinic of my own, more business loans. I totally get it. But now that I'm on the other side, you know, I still always try to encourage ODs and new grads to think about, look into partnership. Look into, is there any optometrist out there, any colleague that you trust, that, you know, you can build a trusting relationship with? Because the nice thing is it significantly brings down your personal debt towards, you know, a practice. Like, you split the costs on everything,
Hmm.
and you split the responsibility. So it is less daunting. I've never owned a practice before. I've never been an employer in charge of staff. Like,
Right.
and Dr. Fravaha hasn't been either. And so we're both learning it together, which is really nice. And I would have never opened a practice, I don't believe, by myself.
Yeah.
And I'm so happy that I did it with a business partner. It's been the best journey so far.
That's
and
good.
yeah, we are a year and a half open now. The other best part is with a partner, we can kind of focus on our own subspecialties with like offering primary care together. But then, you know, I can dabble more into vision therapy and doing binocular vision assessments when I know that Dr. Fravaha is available to do more of the primary care. He's into ortho K, he's into scleral lenses. He's way more comfortable with senior eye care and like diabetic retinopathy. And I'm not. And
Right.
he's not really as comfortable with peds, and I am. So it's like we can really utilize our skills and our specialty skills to the max potential when we share the practice, which is nice.
That's excellent. That's really good. It's actually nice that you guys have that, and with that you have a really broad scope, and you have each of you more specialized. So, for example, Harleen and I are less like you guys. We're more in the sense of we're both more primary care with dabbling in dry eye. We got pretty deep into dry eye, both of us, but we're kind of dabbling in ortho K, specialty contact lens. Myopia management actually for me has become maybe my biggest focus in the practice now. But we didn't train to be specialized in any of these specific areas, right? So we're both kind of like
finding your path.
And it's helpful because we can see all the same types of patients, or I can hand off a patient to her. But at the same time, I like your guys' setup in that you're like really specialized in what you do. He's more specialized in what he does. That's kind of cool that you guys have that, and it gives you a chance to really go deep on a lot of different things.
Yeah.
That's excellent. So tell me about like what was something that was maybe what's the most challenging thing that comes to mind with opening a practice? Oh, actually, before you go into that, are you guys part of a buying group? I can't remember.
Yes, we are.
Which group are you with?
I recommend.
I recommend. And how has that been for you guys as far as being with I recommend? How has that been supportive for you in the practice?
Very helpful. Like I don't even know what I would have done without a buying group. At first, I honestly just thought that it was to get discounts on products. And so I was kind of like, I mean, sure, whatever, great, we can do it. I had no idea before signing up that they had just like an endless amount of resources for learning how to manage a business. They offer business coaching. So you're paired with a coach. The coach goes through all of your numbers with you. They train your staff. Like they have all these training videos for the optical. It's endless. I think, but it's only helpful if you utilize those services. Like you really want to make sure you go on their website and like look for all these things, watch all their videos, get the mentorship. Then it's extremely helpful. I couldn't be more thankful to like a buying group for just kind of helping us navigate how to get around this. And they also offer, mentorship groups. So they'll do Zoom meetings with people within your area who are also new practice owners. So everyone can kind of share their struggles together, learn from each other, share their tips like that. That's been super nice and helpful too, as part of the buying group.
That's awesome. That kind of stuff is invaluable, honestly. So we're part of OSI. So, but it's similar in a lot of ways, obviously different in some ways, but similar in a lot of ways. We were part of a different group before, where we got just the discounts, and we're like, cool, we got a significant discount on this and this and this. But what we felt like we were lacking was the mentorship and the business support and that kind of thing. And so I think it was almost 2 years ago now is when we switched to OSI, and primarily for that, trying to get that business support. And what we found is, because we explored both options, I recommend and OSI, and honestly, I'm not going to say one is not better or significantly better or significantly worse than the other. We just had certain factors that helped us decide to go to OSI, but neither of them had as deep discounts as what we were getting before. So we took a little bit of a hit on some of the discounts, and we thought, no, that's going to affect our business. But then the support we got on the business side more than made up for the discounts. You know what I mean? So now we know how to run the business a little better. We have a coach, or however I can't remember what the official term is, for our person who comes in and looks through the KPIs with us and looks at sales with us and looks at like the numbers and how we can improve things. And we use Optasis now as our software, and that helps us kind of look at a lot of different numbers as well. So I just thought I'd ask you that, because that's something, if you weren't with a buying group, I was going to make that suggestion, like as a new practice, it would be super helpful. Good. Okay. Now to the other question I was going to ask you, or I did ask you, tell me like what's one big like struggle that you had and that you've probably overcome, or you feel like you've overcome?
Oh, I haven't overcome it yet. It's my own personality.
You haven't overcome yet, but what's a big one?
My personality. Like
but that doesn't have to do with your business. That's
no. That affects my business, right? I'm very controlling, and I'm also I speak before I think, and I'm very reactive. I know my flaws, and so actually opening the practice and managing staff members and trying to be a leader amongst a team like is tough, because anytime, bless you,
thank you,
anytime, something doesn't go the way I was expecting it to, my initial thing is to react and tell my staff, why did you do this? Why did you do this? I have learned, over the year that I need to really learn how to be a more effective leader, be more understanding. My husband's so happy because he's like, wow, finally something is pushing you to become a nicer person. I'm like, yeah, because I can't you're not going to run away, but my staff can run away. So I need to, I need to become nicer.
In this current, like, climate, hiring, staffing, HR type situation, you got to be we should always try to be empathetic and all that kind of stuff. But like, people are much more willing to run away, as you put it, these days. Because it always just seems the grass is greener. But I think people are switching jobs so much, realizing the grass is not always greener. But we probably should do our part to try to make our side of the grass look a little greener and support our staff more.
So that's basically that big challenge is what other business owners have said before. It's putting on multiple hats. Like, I know how to be an optometrist. We all know how to be an optometrist. I know how to be a wife. I know how to be, a family member to someone else. I'm learning how to be a boss and an employer, and that's hard. And no matter how much like counseling or suggestions I can get, I mean, I have to change that internally inside of me. That is hard. And thank goodness for Dr. Fravaha's patience level, because if the staff have problems, I think they go to him first, which is a good side strategy that they have, so they don't have to go to me. That's the
good thing. That's a good thing about having a partnership. My staff does that too. So they'll go to me for some things, and they'll go to Harleen for some things. And like, it's sort of a good and a bad, or there's things you can learn from that. Is like, why would they not come to me for those things? Maybe it means I'm not as accountable on things that they want a bit more accountability on, or maybe I'm more approachable with some things that Harleen's not, right? But you take a little bit of lessons from that, like, okay, Harleen, the staff went to Harleen for this thing. Maybe it's because I need to be a little better with something or other, and that'll help in the future. And actually, if you're more conscious of it and open to evolving, I found that they actually have started to come to me for some of those other things a little bit, so I'm like, okay, cool. They're finding me a bit more approachable for this. But on that, so I do a lecture. I haven't done it for a while now, called the eyecare CEO. The other recent episode I did with Dr. Brianna Rue, I talked about it in that lecture too, but in that podcast. But part of that is like, so what I would do is I'll bring guests, or I did a lecture based on a lot of the input I got from guests on the podcast, right? So I do the lecture as if I'm giving a podcast almost. We're doing a podcast, and my first guest is this person, and here's what they shared. And then I go into detail about what that means and how we can bring it into practice. And one of those things was accountability. Accountability is very important for a leader, for a CEO, and not just holding your staff accountable, but yourself being accountable, right? And so for me, what that means is I got to be willing to own anything that happens in the practice. So this kind of idea of extreme ownership, like everything's my fault, right? If something goes wrong, I might get mad. The staff, actually, it was really the staff made the mistake, but somehow it's my fault because I'm the leader, that I probably should have done something to help them. But now if I have to also hold my staff and doctors accountable, so there's different ways to do that. You can use metrics, like here's the sales numbers, guys, and here's where we need to be. But the other thing is, like you said, if somebody does something that they're not supposed to do, how do you approach them then? And one of the one thing we really should try not to do is like say, hey, you did this thing wrong, like point fingers and say, Amrit, it's all your fault that this didn't, really separating the action from the person. So, okay, Amrit, I heard or I saw this thing happen. The patient was unhappy. Like this didn't go the way we wanted. Can you tell me what happened? Versus why did you do that?
Yeah.
Right. And so now you're okay. That action happened. And now tell me from your perspective what happened there.
Mhm.
And I've tried to bring that into the practice, and certainly helps people to be, it takes away some of that initial defensiveness that comes
Yeah.
with accusations and things like that. So anyway, that's something I shared. That comes from that's not my not my own ideas, of course. That's Dr. Justin Manning.
Oh, yeah.
He's an optometrist in Denver.
Mhm.
Is he still in Denver? Did he move? Anyway, Justin's a great guy. Look him up. Okay,
Yeah.
let's get back to you. So your biggest challenge in your practice is your personality. What else?
Yes.
What else is one other thing that's not specifically
Yeah, about me.
that's been hard?
Honestly, it's so much. Like I'm thankful that I can't even think about the hardest challenges anymore because they really were all in the first year of
Okay.
opening. Now that we're in our second year, everything is slowly becoming a little bit more automated. There's more processes that, procedures that everyone is following. But I think in the beginning, the main challenges really were communication between all of us on the team, because when you're a smaller practice, we all weren't practicing together at the same time, because Dr. Farvaha and I were in a lot of debt now opening this practice. We still have to split our time between that practice and our other associate positions.
Yep.
So that we can generate some income to keep this business afloat. And so our team members were only kind of working with us one day at a time. So we never really had in-person staff meetings where everyone was together. We never had phone calls where everyone was on the phone call at the same time. And that break in communication was definitely one of those huge, huge challenges in the beginning, because if we wanted a certain procedure in place, how to greet the patient, or when a patient books on the phone, what are all the points that you're going to bring up on the phone to make sure that they do their intake forms, that they bring their insurance? Do they want to book another family member? You as the optometrist know all these things that you want your staff to do, but then to communicate that with them, implement those procedures, check in with them to say, hey, how's it going? Are these procedures easy for you? Is anything difficult? Are you getting pushback? All that communication was just very broken in the beginning, just because we physically could not all be in the practice together at the same time. And actually, that's funny. You're making me do some like therapy on myself right now. Now that I'm thinking
Yeah,
to
it happens on the podcast. Yep.
right, being a new graduate doctor, when I said, I wasn't happy in a corporate setting. Yeah, it's not corporate's fault. It's those practices that I was in. The owner was never there. I was always there by myself. Staff turnover rates were just so high that it was a new staff member almost every 2 months.
Wow.
And so where was the communication? There was never any group communication of what's happening in the office. Let's prep for these patients. There was no communication, and I wasn't enjoying working there.
Yeah.
And Northern Site made me want to like rip my hair out. And that's why I was so reactive in the beginning to my staff members for not doing something that in my head I wanted them to do.
Yeah.
Now I've learned, I always ask myself, did I let them know that I wanted this expectation? Like, did I actually tell them?
Yeah.
I don't think I ever told them yet. So now I can't get upset with them. Again, it is my fault. I have to make sure we communicate and
Absolutely.
express, what we want and what we all expect.
Absolutely.
Yeah.
So important.
Full circle.
Yeah, absolutely. But that's amazing that you are learning from,
Mhm.
maybe you're just realizing it now, but you are learning
Yeah.
from those experiences that you had before and making sure your practice is different and better. And
Yeah.
you're also helping confirm some things for me. Now I'm older than you. I've been practicing much longer,
Mhm.
and our practice is longer, but still we're working through all these same things continually, right? It's like,
Mhm.
how do we improve communications? How frequently should we have meetings? And
Yeah.
then we fall off and we don't have a meeting for a few months. So, we are always kind of working on these processes as well. And things like WhatsApp and Slack and stuff like that, they help.
Oh
As
yeah.
our teams grow. We've got
Oh yeah.
5, 6 doctors and however many
Wow.
staff now between the two offices, having WhatsApp groups just to make
Mhm.
sure, okay, quickly going to fire these messages out, and this internal messaging systems that we have. messages, or make sure Harleen and I come up with an idea. One of us is designated to make sure the idea gets put out to everybody. So they all know, at least they've heard it once. And then when I talk to them in person, they're like, oh yeah, okay, got it.
Yes.
Awesome. Well, really nice to hear, or it's really helpful to hear your insights there as a recent grad, as a new business owner. I think there's a lot of people out there who can benefit from hearing those insights, whether they're new or not in their endeavors. I think we all, what we find out when we have these conversations, we all are having similar struggles, just maybe at different levels. And then when you share an idea, it could help even somebody who's been practicing. Now, for me, I'm listening to you speak. I've been practicing 15 years almost, but like, oh yeah, that I remembered I should probably do that in my practice, right? It's helpful. Okay. Big part of what you do. Almost everything you do in practice is BV, PEDS, VT, that type of stuff. And there's a lot of us, myself included, who don't do a lot of that stuff. And over the last 12 months or so on the podcast, I've been kind of diving into some of these things and learning from amazing people like yourself in the BV world. Paul Roulette and V2 Bon and others like that, and Kieran Ramesh, who practice BV and VT and stuff like that. And I'm finding it it's blown my mind, honestly.
Yeah.
It really has in such a weird, because this is like one of the key things I want to get into is why is there it's like this massive wall or curtain between primary care and BV, and like us in the primary care side are like, what are they doing over there? We can't really must not be real optometry. But then when you actually get a look, you're like, holy cow, it's like they're doing magic. Like what? Yeah. So there's too much of a divide, and it's like a bit of a black box kind of a feel. All right, so this is a lot to cover in like half an episode here. But first, tell me, why do you think there's such a divide there, primary care to BV? And then I want you to kind of go into, what do you do actually as a BV doctor?
No, those are great questions. And I agree. I just recently recorded our Four Eyes episode with Deepon. And I think in that lecture, I said, people probably look at the BV world and like scream out like, she's a witch. She's a witch, with the torches, like, no, we got to get her.
Yeah.
But it's true. And that's how everyone kind of assumes, the BV world works, especially when they're in optometry school, when they come out, is like, it's all magic, right? It's all like, we're like the BV whisperers. We just look at their eyes and we know exactly what to prescribe, without doing any testing. I truly believe, now that I've been on both sides, coming out of optometry school, practicing primary care, learning more clinical BV related concepts, and now behavioral BV related concepts, I believe that both sides are honestly just at fault together. People, let's say the traditional optometry world might not be more open to behavioral or functional concepts of optometry because every BV system is different. So we don't have a lot of clinical trials, right? Like we don't have those evidence-based clinical trials where we're putting people into these perfect boxes of, you all have the exact same convergence and sufficiency. So let's do one treatment on you guys, the exact same protocol, and let's see if it works. Because everyone's BV system works very, very differently. So when there's not a lot of clinical trials or experimental trials that's considered higher quality evidence, people will not want to accept the other evidence that's out there, the billions of case reports, the hundreds of case series, the decades, almost centuries worth of literature that's out there, because they're all quote unquote now outdated, right? Just because something's outdated, that does not mean that it's still relevant today. So I can see on the traditional side why a lot of BV concepts might not be, welcomed with open arms. But also, I'm now part of that BV world, and I really do think that a lot of BV docs are also being very protective of their information now. Like a lot of them want
gatekeeping. You think deliberately, withholding or
I don't think deliberately. I think it's because I understand it too now. To get into the BV world, you have to dedicate a lot of years to education, and I'll be very honest, a lot of money. Like our conferences are in the thousands for registrations. Our online courses are in the thousands. I mean, I spent one 5-day course that was fully online spent almost like $2,500, $3,000 on it. That's one course for a 4-course program. Okay, that was 1 out of 4. So that's a lot of money when you talk to primary care ODs who are like, whoa, like how are you spending thousands and thousands, tens of thousands of dollars on your BV education?
Yeah.
So now I'm also very protective of it, right? Like if I see an OD asking me, you know, a quick tip on, you know, how do I treat this XT? How do I treat this EXO kid? And I'm like, well, I can't just tell you. I mean, you also have to go through now 8 years and spend $50,000 on your education to learn the same concepts that I learned. So maybe, and I might be wrong, you know, people will listen to this and maybe disagree, and that's fine. I feel that I'm very even protective of what I know because I worked hard to develop that information, to gain that information and develop that experience. And so to share that info with primary care ODs, it really is not a 1 hour, 2 hour CE course that I can share with you at, you know, a conference and
So
you'll know it all.
in that case, like somebody reaches out to you, I probably reached out to you at some point as well. So I apologize. But
I have a lot of people reaching out to me.
In case like I reach out to you and say, I got this EXO, you know, 8-year-old, whatever, blah, blah, blah. You know, what do you think?
Yeah.
You'd be hesitant to share because it's too complex to just be like, here's a quick one sentence answer to fix all the problems, or you're hesitant to share because you've taken all this time to learn it. You don't think it's fair to like just tell me who hasn't done any BV training how to fix that problem.
On a smaller part of me, it's not fair. A larger part is, like I said, everyone's BV system functions completely different. I am more than happy, and I have done this for a lot of ODs who have messaged me on Instagram, you know, DM me or texted me. I will let you know exactly step by step. Okay, do the accommodative test. Do this test. Do this test. Whatever you see, if you see A, prescribe this. If you see B, prescribe this. So I can tell you, and I do share exactly what I think I would do for that child. But now that I've taught you how to help one child with an exotropia, that's not the same protocol for the next exotropia.
Not a one size fits all.
It's not a standard protocol. And then again, let's jump back to traditional optometry. If I'm trying to teach you something that has no standard protocol, no step 1, step 2, step 3, everyone is happy. I mean, how many people are going to be willing to learn it if they don't have the time and they're busy and they're like, well, now this doesn't make sense because now I don't know how to treat every exotropia. You're telling me different things.
Yeah.
So that I find is
which is what makes it seem kind of and listen, I'm coming from the perspective of, as I just said, my mind has been blown. I'm very interested, and I'm coming with a very positive perspective. I'm not judging or criticizing. However, I know how I used to feel just a year ago, 2 years ago, and how other colleagues of mine feel when I speak to them. Colleagues of ours feel. So, you know, it's understandable that like, well, if it doesn't work all the time, that's what kind of makes it feel kind of hokey, right? It's like, well, you're just making this up on the fly. But that's like, but the answer to that question, I'm going to answer it myself. Are you making it up on the fly? It's kind of yes and no at the same time, right? It's, well, I am, because this is a different situation than the last situation. So I do have to do things differently, but you're doing it with a very solid foundation of knowledge and connecting dots that maybe you didn't have to connect for the other patient. So it's a sort of a science and an art at the same time. 100%. It's kind of the feel. But it makes it hard for the average, and I don't mean by, I mean the median optometrist to really grasp it and implement it actually is maybe the bigger thing. So is it beneficial to people in the, the BV world? Is it beneficial or harmful for you or everybody in the BV world to try to give me, the primary care optometrist, some basic level of knowledge in BV? Or do you feel like just don't even bother? If you feel like you have a BV issue, just send it to me. Like, what's the right way to?
I think that is the problem, right? That's like, that's most of the BV world. And even me, sometimes someone tries to ask me a question about, oh, why did you prescribe like this little bit of plus for this? Sometimes I'm like, I'm so sorry. This is too much to text you. Like it's really like, yeah, just send them to me and I'll deal with it. I don't blame people for thinking like that, because if I asked you, like, how do you handle, this complex dry eye case? I mean, and I don't have any, like, dry eye equipment in my practice. You're going to be like, just send them over. Like, it's okay. I'll handle it. It's my specialty. No worries.
Yep.
But to answer your first question, I truly believe that it's actually more harmful to not share even tidbits for primary care ODs, because my personal, very aggressive opinion is that right now, what we're all doing in traditional optometry is semi-harmful
Yeah.
for peds patients. Harmful, what, I shouldn't say that, but it's everything that we've learned of how to treat pediatric BV issues, amblyopia, strabismus, any of their refractive conditions, is treating a symptom. That is how traditional optometry approaches treating these conditions is, we see an eye turning out. Well, let's give it basin prism because it'll shift the image out. And so the eyes will feel better. If we see, high hyperopia, let's prescribe the high hyperopia and get their VAs to be as sharp as possible. And we're not asking the question, why did the hyperopia occur in the first place? Well, okay, well, they have amblyopia. Well, how did the amblyopia come out in the first place? What age were they when this amblyopia started? And why were they not born amblyopic straight out the womb? And right, like, traditional optometry is not asking those questions. I'm not even going to talk about myopia, because that is like a lot of people messaging you.
We're going to schedule the second part to this conversation. We're going to have to schedule that shortly.
That'll be a different.
I want to go into that. I want to go in deep into that.
Yeah, but not today.
And I appreciate you. You're a great podcast host, but you make a really great podcast guest, because you're open, and like you said, sometimes maybe you speak before you think, but you're obviously very smart and educated in this area. So it's okay if you speak before you think, because you're speaking based on your foundational knowledge. But we need to ruffle a few feathers and shake a few branches here. We need people like that. So to go back to my question, I'm glad you answered it the way you did. Is like, is it harmful or is it beneficial to BV? It's not even if it's harmful or beneficial to BV. Your answer was even better. It's beneficial to all of optometry and to our patients that at least some of this knowledge is being shared, and there's more awareness on these things that you're very strongly opinionated on. And it's good that you are, because nobody listens to somebody who just dances in the middle of like, oh, I don't know, maybe it's good, right? We need some of this strong opinions. But I would, and so I'm saying this to traditional primary care optometry, and I'm saying this to any BV people listening. BV people, please try to share some information. Like, I've seen a little bit behind the curtain, and I'm like, wow, this is so cool. And I'm not going to go spend tens of thousands of dollars to get myself trained. Yeah. But now I understand, like, I'm going to send the patient to someone like you, because this could really change their life.
Now you get it.
And so I have in the last little while scouted out who are and there's not that many, but who are the BV people around me that I can trust, that I can refer to. And I've sent multiple patients in the last few months. Yeah. I've spent more patients in the last 12 months than I did my whole career before that. Yeah. Right. Because now I'm like, there's something there that these kids at least need an evaluation. So going on a tangent, I apologize, but I appreciate the answer. And you're absolutely right. Like, anytime I think about patching a kid, I feel really bad.
Oh God, I'll murder you. Like, I really will.
I think about you, and I think of you too.
No, you know what it is?
Patch this child.
Trust me, I have had ODs push back on, I want to lecture more about these things. I've had some pushback on lecturing about these things that are considered non-traditional, approaches to pediatric care or amblyopia. And, this voodoo magic, I don't want my, my ODs exposed to these things. I've had people that are very hesitant for me to share those things. Yeah. I love right now to use like dry eye analogies, because honestly, I'm out of that big primary care world. I'm very heavy into BV right now, but it seems like obviously treating dry eyes is such a huge thing right now in the optometry world across North America. And I love to use the analogy, and I tried to explain this to another OD who initially had pushback for me to share more on, behavioral approaches to peds, is that we know so much about dry eye syndrome now. We know that, the symptoms that you get from dry eye disease are the burning, the stinging, the fluctuating blurry vision, the scratchiness, the dryness, whatever it may be. And, at this point, with how much knowledge we have, if we just treat dry eye disease with an artificial tear, even if we do it, we know that it's not enough because we are just treating the symptom. And, it's not wrong to do that. You can have a dry eye patient in your chair and say, here's this artificial tear. It's not unhealthy. It's not dangerous for you to use an artificial tear. When you use it, you'll immediately feel better. Your symptoms will be gone. And you know what? You can actually just use this artificial tear for the rest of your life, and you'll always feel better when you use it. Great. That is one way of treating dry eye syndrome. And what I said just triggered every single person who has done more CE and learned more about dry eye disease. Because now you have to say, sure, you can use the artificial tear now, but even before that, let's figure out what the mechanical cause was for the dry eye with the lid structures, your environmental exposures, your hormonal changes, yada, yada, yada. And if we treat the underlying root cause of the dry eyes, you may not even have to use artificial tears, or you may just need to use them once in a while, and your symptoms will gradually resolve. When we are treating, pediatric patients with the prescriptions that we're prescribing them, whether it be for amblyopia, strabismus, whether it be for like just high refractive errors or BV conditions, traditional optometry is still to this day teaching how to treat the symptom of blurry visual acuity. We are trained to just prescribe glasses to improve visual acuity based on the refractive error that we measured. Once you get into understanding how children develop, how their visual process works, you start to realize that there's a reason why they developed a high refractive error. So if you are going to prescribe the high refractive error, you have just given them an artificial tear, and you have told them, wear these glasses full time. You will have this prescription pretty much for the rest of your life, but you will see better, so you'll function better. And that's true. They do, right? You'll see these 50-year-olds with +6 in their lenses being like, yeah, I've seen the eye doctor since I was like 3 years old. This is the lens I'm in for the rest of my life. And they still grow up to live their life, and it's not wrong. But you have not addressed any reason as to why they became a high myope, why they became a high hyperope, why they have with the rule sill, why they have a CI, an XT. Like, you have not addressed why that happened in the first place. And so just like with dry eye syndrome, you have all these other treatments, not even just IPL and RF and lid scrubs. That's also kind of just treating like chronic conditions that are on the surface. What caused those meibomian glands to become dysfunctional in the first place? Probably the gut microbiome, probably, nutritional issues. So even then there's an underlying layer. And so when we start to treat the child's binocular vision system before giving them clear visual acuity, if we prescribe lenses or therapy or counsel them to improve their stress response to things up close, their binocular vision system, their visual acuity slowly improves on its own, and their refractive error can actually lower or completely stabilize. And so like that, and that's my goal, is to lecture more on these concepts, because I do want primary care ODs to know that information. Whether or not you want to start applying that to your practice, that's totally up to you. But now that if you understand that, yeah, you're more inclined to refer to a BV doc who can prescribe the lenses to stop their refractive error from growing and changing.
Right.
Versus just prescribing it.
Right. And okay, so
that was a lot.
No, that's great. So, and we're not just talking. So if we're talking about myopia, for example, of course, myopia management is a big topic these days. And I personally speak on it, and I practice. I see a lot of myopia kids in our practice. When you're talking about prescribing prescribing lenses to help slow down or stabilize the myopia, we're not just talking about some of the more mainstream myopia lenses that are on the market. We're talking about different other types of lenses that you might prescribe or other types of prescriptions outside of that. Or
Yeah, I mean,
we're referring to those lenses that are like the DIMS and the HALT
I
lenses.
don't use any of those.
Okay, so that's what I mean. Okay, so
And
that's what I wanted to get at. You're not talking
yeah.
about those. So those are like the mainstream lenses that I would
Mhm.
prescribe in my
Yep.
primary care practice, but you're prescribing something completely different. I just wanted to
Completely
differentiate
different.
that because I don't want someone
Yeah.
to listen and be like, oh yeah, she's prescribing, the Hoya Miosmart or the Stellus lens from Essilor or
Yeah,
whatever.
and
Um,
I can just quickly touch on that because again, those options are not bad options for kids. Again, there are clinical trials on those. There's evidence based that those treatment options work. What I believe that those treatment options are doing, like any of the DIMS lenses, the MiSight contact lenses,
mm,
atropine, all of these in my mind, I'm relating those to like giving medication for, high blood pressure. It's well researched, it's effective. Those treatments are mainly aiming to slow down axial length.
mm,
But again, I don't think any of those treatment options have asked the question, why did axial length start changing? Why is it still growing?
right.
Well, it's changing because the myopia is increasing. Why is the myopia increasing? Well, because the kids are doing a lot of near work. Yeah, but everyone does near work. So why are you do a lot of near work, Harbier, and I'm sure you did when you were a kid too, ish. Well, you're an emmetrope, so you're fine. But
Yeah.
every kid does near work. So why is every child not developing high
Right.
myopia? There is a physiological stress response that certain children develop to adapt to how uncomfortable their eyes are with near work. You can have this is all part of functional optometry. So when we do a near task, it's not only the act of looking at something up close that could be discomforting, it's the cognitive demand of understanding what we are looking at. So when kids enter grade 1 or grade 2, they're not just doing a lot of near work at school, they're learning new concepts in those textbooks, in those papers, in whatever they're learning, their ABCs, they're reading, they're writing. If a child cannot handle that cognitive demand while they're looking up close, they'll develop a stress response. And their stress response will do two things: fight or flight.
Mm-hmm.
Flight are those high hyperopes who don't want to look at anything up close, and those exotropes who don't want to focus up close. They're the ones labeled with ADHD, attention issues, fidgeters, class clowns, disruptors, because they fly away from that discomfort. So they don't like to do near work. People who develop myopia are fighters. So their visual system and their body and their posture and their breathing physically starts changing to say, I'm uncomfortable right now looking at this book and trying to understand it. I'm going to change the way that my visual system works right now. I'm going to really screw up my convergence and my accommodation right now so that I can see more comfortably up close. And now that I'm comfortable, I can keep going. And when I'm comfortable and I keep going, I accommodate more and I accommodate longer. And so what's happening with accommodation? We're contracting the ciliary muscles, we're increasing the vitreal chamber pressure, and there we go, axial elongation occurs.
Interesting.
Axial elongation happens even after 5 minutes of reading. And when discontinuing, it goes back. It's almost elastic. It actually goes back down to where it was prior. But extended near work with extended stress response will cause axial length to keep growing.
Wow.
Yeah. Okay. I said
Okay.
I wasn't going to do this here,
No,
but I
I'm
did.
so glad you did.
Yeah.
That's
So asking those
incredible.
questions,
Again, like
right?
changing the way we're looking at our patients and how we're treating. So you use a term in there that I wanted to make sure we highlighted.
Mhm.
And I know you talk about it on Instagram. I like your posts where you're sharing these types of tidbits of
Mhm.
information. Functional optometry, that was the word you
Yeah.
used. And functional health, functional medicine, these are terms that are being used more and more.
Mhm.
There's functional medicine doctors who are,
Mhm.
MDs, they're GPs essentially, but they're practicing,
Yeah.
looking at the kind of underlying functional issues that might relate to blood pressure, for example.
Yeah.
A
Yeah.
traditional GP will say, well, here's your blood pressure medication.
Yeah.
Functional medicine doctors gonna be like, what's causing the blood pressure to go up?
Mhm. Yeah.
Is it your diet? Is it your health? Is it genetic
Yeah.
factors? What else is it? How can we alter those to improve your long-term health, and you're doing that from an optometry perspective. I know it's not a brand new term that you came up with, but it's not a term that we use ever. So I think it's really cool that you are using it. And you made a really great analogy to dry eye with the artificial tears, and that made me think of our friend Dr. Mila Yusufova in Portland. She's a great lecturer on dry eye, but she does the same thing with dry eye. She's a functional dry eye doctor, right? She refers to functional medicine a lot. She's done her certificate in nutritional health and all this kind of stuff. So she's diving deep into that world on dry eye. I love that you're diving deep into functional health in this pediatric care, binocular vision. It's really, really cool, and it's a really big wake-up call for me. Like, we are just missing such an now we look for me, it feels like such an obvious thing. Right?
Let me be clear, because again, I don't want to say that there's any like negativity amongst like myopia control treatments out there. I mean, I'll be shunned from the
we're not knocking the treatments. No. So we mentioned those. Sorry. Yeah.
They're huge. They're huge right now.
But like I speak on these technologies, so I don't want to like.
Of course they work. They're great.
You're working in a totally different world than I am.
It's a different approach, right? So I educate parents on whether it's myopia or hyperopia. Again, I kind of categorize them all in the same boat, because any high refractive error is not normal for a child. So it's not just myopia is this and high hyperopia is that. It's all together. And so I don't use traditional or conventional myopia control methods, because you can, and it's not wrong, but it is treating that symptom of chronic BV stress. Axial length, elongation, and higher, myopic progression means that the child internally still has a stress response to how they do near work. And so what I prescribe is mostly reading glasses for myopia control, and for hyperopia, I prescribe near glasses to lower that stress response while they're reading something. And it's been shown to be very effective. It's so when we say bifocals don't work for myopia control, the bifocals that were used in a clinical trial trying to put children into a category and trying to throw a +2 bifocal on every single one of those children is, of course, not going to work. Not at all. Right. But when you put the right bifocal and the right add power on each child individually, almost every single one of them don't progress. Some of them reverse their myopia. Some of them don't progress, and most of them slowly progress. And then you have the ones that still feel stressed all the time. And I'm like, well, you know what? I can't help you anymore.
Yeah, like, that percentage. Yeah, let's be clear. Even the best tech treatments out there that we know are none of them are anywhere near 100%, right? So, although our friends in Ortho K, in the Ortho K world, are strong believers that Ortho K works very, very well. I'm not going to go in there because I'm not an expert. I do fit Ortho K, but what was I going to comment on there? Your reading glasses.
Yeah.
So, can you tell me, I know, again, we don't want to, it's not a cookie cutter approach, but like what kind of reading glasses are we prescribing? Let's say it's an early myope, low myope, or maybe even just an emmetrope that you're concerned may progress to a myopia. What are we prescribing as far as reading glasses?
Everything is different. There's definitely rules of thumbs that work for majority of, patients, whether they're young or old. Low plus prescriptions are great and very comfortable for majority of the patients that you have. So +1/4, +0.5, maybe 0.75. But again, because there's no standard protocol, it's even hard for me to tell you that, because I don't want you to take that and then give the wrong patient +0.5, because it's quite uncomfortable. Yeah. And so for any myope, I usually try to give less minus for near. Whatever I give them for distance, I try to cut it back at least 1/4 or more for their near prescription, which leads to me just giving a bifocal, because it's a multifocal. Like I don't want them in 2 separate pairs of glasses, and the other conventional options aren't designed for bifocal use. So, bifocals and anti-fatigue lenses are usually what I end up using. But that's kind of where, it's not available yet, but I'm trying to get more of this information out there for primary care optometrists by creating like an online course that anyone who's interested in just getting exposure to this world, trying to build this bridge between BV and the primary care world, can take this course, learn about those functional concepts, like from infancy. You know, how does a baby develop? How does their BV system develop, you know, at 6 months old? And how does their far vision, you know, negatively change if their BV system when they were younger becomes disrupted? And it basically is a great way for optometrists to learn all about it. There are prescribing tips in there for how to prescribe for infants, toddlers, and school-age kids, how to prescribe for amblyopia and strabismus, that you can start to practice in your primary care clinic. And then, of course, if my course isn't enough, which it obviously isn't, there's so much more out there to learn. All the resources, all those hidden gems that you cannot find in a primary care world are added in that course, so that people can then learn more from all the courses that I took and all the things that I know about. So it's kind of like a primer, or like an introduction to all of these concepts, so that it doesn't seem like voodoo magic.
Yeah.
Like it is effective. You're just taking a different approach.
Right. I love that. That's awesome. I'm glad you kind of naturally got there, because I definitely wanted to make sure we talked about that before the end of the podcast. We have run a little bit long, and I know you got to get to work, so we're going to wrap it up in just a second. But so much value. Like, this is going to be one of my longest episodes, over an hour, but at the same time, there's just so much value in here. And I knew the BV thing was going to be a big thing, and we're not done. There's still more things we could talk about. But the prescribing the low plus, I'm really glad you said that, because I've been doing that for a long time, and I'm so glad that there's actually benefit to it, because I just intuitively, that a lot of, again, I don't have the deep background knowledge that you have, and maybe I'm still doing a bit too much of a cookie cutter plus a quarter plus 50 for different kids, but if they got a bit of SIL, I might throw that in there, but I'll talk to parents, like if it's an emmetrope, or, whatever it might be, a low plus, low minus, I'll talk to them about that, and how, they come in asking for blue blocking. I'll say, well, blue light blocking is not the important thing here. It's like, how are the eyes focusing? How much effort are they putting? Like, we can give a really small number, and we'll add the blue light blocking in there just because you want that, right? But the really important thing here is that little tiny prescription I'm going to write is just going to help the eyes to relax and not focus as much. Now, that's my simple description to parents. And I'm glad to hear, at least I'm on the right track. I may not be doing it perfectly, but
you're part of the BV world now. Welcome.
I did it. Did it.
Yeah.
I'm there. Awesome. Okay, Amrit, tell us, where can we find your course, and where can we find you to learn more about you and what you're doing?
To find me, I'm definitely on Instagram. That's my main platform. So it's at dr.Amrit Bilkhu. And the pediatric masterclass that I'm creating is going to be available just on a third-party website that anyone can purchase, log in, and do at their own pace. I think it's running around maybe 9 hours of a course right now.
Wow.
There's like 5 modules, 20 lessons. It also follows a timeline. So it starts literally from when the child is born all the way to school age years, so that you're comfortable and more confident prescribing for infants, babies, toddlers, and school age kids. There's tons of like PDF handouts that are going to be part of it, lots of articles that are part of it. And I am in the works of trying to get it COPE approved, so that I can, distribute it through an organization if possible. But for now, I am aiming for it to be out in March 2025. So I'll probably be sharing more info about it on my Instagram account. And you guys are more than welcome to just DM me on Instagram if you're interested in learning more. And
is there a link we can share right now, or not yet?
Pardon?
Is there a link we can share?
No. I was actually editing it all morning. I have like 3 more lessons to edit, and then it'll be out.
All right. Okay. So it's maybe not live just yet, but that's okay. So whenever you hear this or watch this, just message Amrit on Instagram at least, so you can get the information. And maybe after it does go live, I'll just add it to the show notes or whatever after the fact, if somebody happens to listen to this a couple months from now. Instagram handle. Oh yeah, it's at dr.Amrit Bilkhu. And actually, for anyone, dr.Amrit Bilkhu. Yeah, sorry, but it's dr. Amrit Bilkhu,
Oh,
right?
sorry, DR. Oh my gosh, yes.
Yeah.
dr.amritbilkhu
Okay, got it.
is my Instagram handle. And actually, for anyone who lives in BC, I will be presenting for the
Yeah.
first time at the BC Docs conference
Amazing.
on
Amazing.
Sunday in May, whatever day it is.
Yeah.
And I'll actually be going through the kind of the functional concepts behind myopia onset and progression and psychological factors that contribute to myopia as well. And then sharing those BV tips on how to know who's going to be a fast progressor, who's not, and just tips that you can start to use in your everyday practice. So I'm excited for that. And hopefully nobody calls me a witch from the audience when I lecture about it.
I'm gonna make sure I'm there, so I'll protect
Yeah.
you if they do.
Awesome.
Maybe might even be able to introduce you actually. So I'll see if they
Oh, yeah, that'd
do
be
that. I'd love to,
cool.
because then I can just put a warning out in the beginning, like if you call her a witch,
Color-
come after you.
You should bring a torch and then you should be in the back doing.
Oh man. Okay, I gotta let you go because I know you
Yes.
gotta get to work.
Thank
But
you so
any
much.
quick final words? Anything last thing you want to share before we wrap up?
Final words is like, honestly, the BV world looks very scary from the outside. On the inside, it is very friendly, very welcoming, very open to anyone who's interested in diving into the BV world. And so, hopefully with my masterclass that's out, it doesn't feel like you have to jump right into the deep end of the pool. You can take those little baby steps, in the staircase and go from the shallow end first. So
Awesome.
I encourage everyone to be more interested in BV so that you can treat your pediatric patients with a more functional approach.
Love that. Awesome.
Yeah,
Thank
thank
you. Really
you. That
appreciate
was
this.
great. That was
There's
fun.
a lot of really good info in here, and
Yeah.
I hope you, whoever listened, please make sure you listen all the way to the end. I hope you did, because there's just so much in here. So thanks, Amrit, and thank you to everybody who has tuned in to the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys in the next episode.